Hello, everyone. Welcome to the American College of Medical Quality's virtual speaker series produced and brought to you by the college's Education Committee. My name is Angelica Tom, your coordinator here at the American College of Medical Quality. Today's webinar is titled Health System Science Education, Preparing for the 21st Century Healthcare System. Our presenter is Dr. Jed Gonzalo. He's an associate professor of medicine and public health science and associate dean for health systems education at Penn State College of Medicine. Before I turn the program over to Dr. Gonzalo, I would like to review a few housekeeping FYIs. Today's complimentary webinar is being recorded. All registrants will receive the archive and a follow-up email from me after the conclusion. It typically takes about a few hours. The email will also contain a link to a short survey. Your feedback is invaluable to the college's education committee in creating new educational programming, such as today's webinar. Dr. Gonzalo has provided a few printable versions of his slides, and you will receive those as well in the follow-up email. If I can let you know that all participant lines are muted during the session. You will be able to participate in a question and answer towards the end of Dr. Gonzalo's session today, and you will use the questions module box in the console. It's typically located on like the lower right side of your screen. Just direct your eyes to your console and find that, and you can enter any questions at that time. Now, should you have any technical difficulties, please direct those issues over to me. You will just you can place them in the questions box, or you can put them in the chat box. Either way, and I will respond as I'm monitoring those issues. Or if you need, feel free to email me at atom@acmq.org. That's atom@acmq.org. Now, it is my pleasure to present to you Dr. Jed Gonzalo. He graduated from the University of Scranton with degrees in biology and philosophy, and he received the Frank O'Hara Gold Medal Award, which is awarded to the student with the highest GPA in the colleges of art and science. He received his MD from Penn State College of Medicine in 2006, where he was inducted to the AOA Honor Society and chosen by his classmate as classmate you would most want as your physician. Well, that's a high degree for me. He then completed his internal medicine residency and chief residency at Beth Israel Deaconess Hospital in Boston, where he was an instructor at Harvard Medical School, and he was awarded the Lowell McGee Award, which is given to graduating residents who most demonstrate the fundamental importance of teaching to the spirit and substance of being a physician. Following his residency, he completed a fellowship at the University of Pittsburgh in general internal medicine and medical education, earning a Master of Science in medical education and clinical research in conjunction with this fellowship. In 2012, he was recruited back to Penn State as a clinical investigator educator. His work focuses on two areas critical to Penn State's health mission, exploring the relationship between education and practice in systems and care. The second part of that mission is leading the emerging field of health system science education. As Associate Dean, Dr. Gonzalo has led the design and implementation of 12 programs related to health system education, which has garnered national recognition, including coverage in the Washington Post, Wall Street Journal, and the U.S. News World Report, NPR Radio, and AMA Newswire. He has a well-established track record for publications with more than 50 peer-reviewed manuscripts. We are just delighted to have him here, and he has emerged as truly an expert within this field. So it is my pleasure to turn it over to you, Dr. Gonzalo.
Angelica, thank you so much for that kind introduction, and thank you to the American College of Medical Quality for this fantastic opportunity. And for those of you on the telephone, on the webinar, thanks for joining in. I wish I could see your faces. And I'm really excited to be presenting some of this work that's been ongoing for the past number of years. There's a Penn State logo on your opening screen, but I will say that I happen to be part of an AMA-led consortium of medical schools that is leading work in this area. So I'm really representing their collective voice as well, led by Dr. Susan Skochalak at the AMA. And I know this is a little atypical looking at your other webinar series titles. This is a very educationally framed session, which is exciting. But when I map all of your other sessions, they map to the health system science framework, which is exciting. So Angelica has given you the title, so I will shift to the objectives. If I can get the screen to go to the next slide. I'm hoping you can see that. Here are the objectives. I've listed four. We'll define the health system science framework and describe its role in medical education. And for the second and third, we'll talk about the role of the clinical learning environment and the need for clinical learning environments to be expanding the health system science competencies. And we'll talk a little bit about the concept of value-added medical education. And we'll discuss the challenges to integrating health system science into medical education. And this is, I hope you'll find, certainly applicable to no matter which role that you're in your health system. So I'll do this through the form of three questions and three concepts. I'll ask a question, I'll go through the concept briefly, and then we'll go to the second question and so on. And I'm hoping this doesn't take the whole time. So here's the first question. I'm going to ask Angelica if she can facilitate the question.
Dr. Gonzalo, it is up on the screen. I know you can't see it on your end, but audience, if you would kindly select either yes or no to the question, healthcare professionals have received sufficient education to optimally function in involving health systems. So please go ahead and enter it. Right now, about 67% of the audience has voted, and they've all voted 100% no. So let's see, I think we're almost there. There we go. Okay. So it was a 100% no, Dr. Gonzalo. So I just want to make sure that you still have control of the slides. So please go forward.
Okay, so that was a big softball, as you all kind of demonstrated, voting with your feet. And that's where I'm going. This is really the burning platform, the very fact that we have 100%. I mean, the N here could be 4. I'm not sure how many people are on the phone, but 100% of people on the phone identifying that the answer is no, that the optimal education, this educational continuum, leaves much to be desired. And that is really the burning platform for this first segment of some of my message today, which is concept 1. Health system science is the emerging third pillar. I'm using that in quotes of medical education. This is an iceberg figure, the iceberg of healthcare transformation, which we have in our chapter 1 of our textbook, which is entitled Health System Science. And I hope this strikes a chord with most people on the phone. Care provided to an individual patient is what lives at the tip of that iceberg that we can typically see above the waterline. And what lives below, but intricately connected to, not disparate from, are the concepts, the skills, the structures, the processes that allow us to provide care to an individual patient. In many ways, this is a healthcare transformation. The parallel path to this is medical education. Medical education really has focused the past 100 years on the tip of that iceberg, coming up with a diagnostic and therapeutic plan for an individual patient in a room. And certainly there is no argument that that should go away. That is absolutely critical and should remain. But what lives below this waterline that is still connected are concepts that allow us to be most optimal in the tip of this iceberg. If I were to log the number of hours or contact time in my medical school, my medical education, that live below the waterline on this figure, it would literally be between 2 and 4 hours. It came before the AAMC guidelines for behavioral and social determinants of health. Medical schools should be teaching this. So we might have gotten 1 or 2 hours there. And somewhere along the line, someone taught me about electronic health records. But really, I had never heard these terms before residency. In fact, all the way in the fellowship. I did not know what Medicare and Medicaid was, embarrassingly so until fellowship. So that is really the shift. And again, the burning platform for the medical education transformation. It's paralleling the healthcare transformation. Almost to the year, for a century, medical education has focused on 2 pillars, the basic and clinical sciences. This stems from and originates from Abraham Flexner's work as he consolidated and named what had been going on in medical education for several years prior. But he said medical schools should focus on the scientific principles, scientific inquiry. We should be placing learners and medical students with physicians who are in practice in the apprenticeship model to learn the clinical sciences. And up sprang this 2+2 model, 2 years of basic science, sit in a classroom, learn the basic sciences, go out the last 2 years and apply those basic sciences in the clinical sphere. The past several years has seen this emergence of a third pillar, health system science. This does not replace the basic and clinical sciences. It does not suggest that the basic and clinical sciences are not critically important, but it is a consolidation of a new set of competencies that really balance and synergize with the basic and clinical sciences. And in my view, is really what patient-centered care is. And I'm hoping I could at least nudge your thinking in that direction. Uh, And here's the textbook. The textbook came out in 2016. There are a number of textbooks that relate it, you'll see, to the health system science competencies or content areas. For the past 3 or 4 years, though, there is a cohesion, a coming forth of several different sciences into this third pillar of health system science. I'm rewinding the clock a little bit to the systems-based practice competency domain. I'm hoping that many of you have at least seen this phrasing or terminology. It started in 1999, give or take a couple years there, by the ACGME when they put forth the competency domains. And this was one of 6 competency domains, and they said that residents should demonstrate an awareness and responsiveness to the larger context and system of healthcare, as well as the ability to call effectively on other resources in the system to provide optimal healthcare. Certainly, when we started our work at the AMA Consortium in 2013, there were initially 11 schools. Now there's 32 schools, but a good chunk of the schools, probably one of the biggest themes, was the fact that the medical schools wanted to be teaching learners how to be best equipped and best prepared for the health system. And when we started our work, we went to the systems-based practice competency. We thought this is a great place to start, and certainly it is. But it became a challenge, and it became pretty clear that this is very nebulous. How do you design curricular or educational opportunities around this phrase in this box? How do you evaluate systems-based practice? I entered residency in 2006, and the systems-based practice domain has been on my evaluations as a learner and for the past 6 or 8 years as a faculty member. And it's very hard to assess and evaluate. So that's what sprang forth a lot of work nationally to begin to articulate and add meat to the bones of the systems-based practice competency domain. And that is what is the living and breathing health system science competencies, which I'm going to talk about on the next slide. And I will highlight before I get there that this comes from several research projects at both the UME and continuing medical education or faculty level. And there's a convergence also at the GME level. So it's not just medical school specific. So here's a blended model of the health system science competencies. And I have citations at the bottom. They'll be on the handouts as well. But this is a blending of several of the research studies. But this really, to me, is the comprehensive lens of health system science that is adding more meat and bones to the systems-based practice competencies. On the left, there are functional competencies, those knowledge, attitudes, and skills that allows a healthcare professional to be functional within their clinical microsystem or facet of specialty. The foundational competencies on the right, and these are more boundary spanning or broad spanning higher order competencies that allows one to be functional within their clinical microsystem. Now, certainly, these are concepts that I am going to make a safe assumption that everybody on the phone has seen before. Medical schools have seen these before as well, dating back 20, 30, maybe 50 years plus. I think what's different about it is that this is, again, a comprehensive framework. In former years, I would make the argument that medical schools, if you were in a medical school that had a department of, let's say, population and public health, you might have had a mini course in the medical school based upon the local expertise on population and public health. Or if you had a value-based initiative in your health system, you might have had a couple sessions there that really focused upon value from those content experts. What has been changing the past couple of years is this comprehensive frame, an educational framework that says we need to be comprehensive. We need to establish this as a field. We need to say this is a critical component of healthcare professional education. We need to figure out assessments and evaluation methods as well. And it's not easy. There are many challenges to this, one of which I think is a shift in nomenclature and language. There's been, as I said, several textbooks that have come down the pike, value-based care, there's informatics textbooks. Health system science, we went through 16 or 17 different names of what to name the third pillar in and of itself in the consortium. And that just happened a year ago. So this is truly, in my view, an evolving framework of health system science competencies. This happens, I'll show you in a few slides, this happens to serve as the framework of all of our educational programs at Penn State that I'm leading. And there's a lot of pluses and challenges to it. I will highlight this as systems thinking. There is something unique at least in my view, about the role of systems thinking as a higher order competency and foundational competency for health system sciences. And I'm just giving a little trigger here to the examples of systems thinking tools. This comes from the Waters Foundation, which is a not-for-profit foundation that has sought to inculcate systems thinking into education in general, not technically medical education. We have been using this as a key pillar and foundational framework for all of our health system science coursework. So the take home from this slide up to this point, I'm hoping that you'll take a comprehensive lens of health system science competencies that expands the systems-based practice competencies. Certainly, these competencies are not ones that can only be developed within a classroom setting. This is not a knowledge transfer, learn A and B, repeat C and D on a multiple choice exam. The critical role of the clinical learning environment cannot be stated differently. This is so critical for our learners to be in the clinical learning environment, to be practicing and doing these competencies, and also seeing other healthcare professionals demonstrating. So I just wanted to highlight the LCME, the Liaison Committee on Medical Education, and the Accreditation Council for Graduate Medical Education, what they say and what their language is for the clinical learning environment. The LCME, this comes from the data collection inventory. If you were to do a search on what medical schools are required to do for accreditation, this is the only location that clinical learning environment exists for the most part. And it says that a medical school must ensure the learning environment, etc., at all locations is one in which all individuals are treated with respect. And certainly there's a lot of view on mistreatment of learners within the clinical learning environment. But notice how there isn't more expanded view to say the clinical learning environment needs to espouse and to role model and or supervise the health system science competence. There's a lot of reasons for that. At the ACGME level, the clinical learning environment review process, which started in give or take 2012 for the past 5 years, has been going to residency programs in the clinical learning environment and reviewing and assessing where the focus areas should be. And these are 6 areas that the CLEAR review has identified that GME programs and health systems should focus on. And 1, 2, and 3 I'll highlight are all health system science competency areas: patient safety, healthcare quality and disparities, care transition, and of course the health system competency framework I just presented is much more comprehensive than that. But the clinical learning environment review is saying that health systems themselves have a lack and a paucity of demonstrating and doing patient safety and healthcare quality, and it's having its impact on the graduate medical education program. And we need to shift focus, and they're recommending for closing that chasm for our GME programs and our health. My hope is that over the next several years, we will see the LCME and the DCI, the Clinical Learning Environment Review, even take on a more broad scope that is more representative of the health system science framework. For example, high value cost conscious care. We know that we have a lot of ground to make up in the clinical learning environment that are both important for UME, GME, and also other health professions. Take home point here is that the clinical learning environment is critical for health system science competencies. And I think the accreditation areas are beginning to shift. This is just a sample of what we're doing at Penn State. It's not necessarily to promote what we're doing at Penn State, but I do want to give a feel of what medical schools and academic health systems are doing. On the left, I have charted out UMEs year 1 through 4. The orange is GME, and the purple is faculty. Again, we're using the same framework I presented a few slides back. Within 1 month of entering medical school, our students are enrolled in SHS, Science of Health System 711, where they learn the core concepts of health system science, and they're embedded in the health system as patient navigators, which I'll comment on in a few slides. In their second year, they extend their work of the concepts of health system science. This is for everybody. I have an N of 150 students just to highlight that these are not elective. We view this as a key pillar of medical education. At Penn State, our 4 pillars are basic science, clinical science, health system science, and humanities. And the students know that coming in, and there's almost equal weight on each 4 of these pillars. We're beginning to integrate them more into the clerkship, which is sometimes a challenge because there's many different clerkship directors and different areas, which makes it challenging. The 4th year, we have a required course, Translating Health Systems. Again, it's all the health system science components for everybody. We're developing several electives. At the GME level, we're launching 2 programs this year. That's why it's in green, because they're not quite launched yet. But there's a core health system science curriculum for all the GME programs. We're starting a resident immersion week, which is, again, all the health system science coursework that the medical students are learning. And I think a feather in our cap is the faculty development program. It's the Health System Science Academy. There are many faculty development programs that exist in academic health systems in the U.S. As you read the literature, there's only one that we know of that is using this comprehensive frame in health system science, and that's East Carolina. Most of the faculty development programs really zero in on quality improvement, patient safety, or leadership. But if you rewound the clock to that competency framework that I presented to you, that's what health systems leaders are saying that our learners, not only students, but also faculty or physicians, should be able to know and do. And that's why we're taking this more comprehensive approach. So again, this is just a taste test of what one medical school and academic health system. Angelica, if you can help me with the second question.
Sorry,
I
audience,
realize,
I was on mute. My apologies. But everyone has started to participate on the question that is in front of them, which is when medical students are on clinical rotations, they are they to you? Number one, an asset. Do they add value to care delivery and help advance the team's work for the patient? Or the number two option, a time and resource liability, with quotey fingers around liability. They tend to require more work and an investment than the value that they add. So right now, Dr. Gonzalo, we have about 70% of the audience reporting, and it's about a 78 to 22 who consider it an asset versus a liability. I think that's where the final stand is, whereas it's 74% an asset, 26% a time and resource liability. Is that how you typically find the results, Dr. Gonzalo?
yep, that's exactly where I'm going, Angelica. I'm going to switch to the second concept. Fascinating results. I will say I've asked this
Oh,
question nearly every.
I think we lost you for a moment, Dr. Gonzalo. We can hear you now.
Okay, let me go to the second concept and I'll build upon those responses. The second concept is value added roles can improve alignment with clinical care while also enhancing education and health system science. So I've asked this question in nearly every talk I've given the past 4 years, and I cannot get rid of the question because it's usually in person, it's a great discussion starter. And give or take, to answer Angelica's question, it's 50-50. There's always somebody in the room who will say, yes, they're definitely an asset. They bring value by their presence, and it increases the academic rigor. Patients love it. it we're all in our A game when students are around, which is great. And then there's always the next counter statement that says they are a time and resource liability. They take time. It's resources for us to enculturate students and to accommodate students in the clinical learning environment. And I don't think there's a right or wrong answer. I'll cite some studies. I'm citing them here at the bottom in citations. They're very old. There's not a lot of recent data. But when you look at when you have students in a primary care clinic, typically by half-day session, they add 30 or 60 minutes per session to the preceptor's role. And you ask those preceptors, they might give you a mixed response as well. They might say, yeah, but that's my job, and students are an asset. Increasingly, though, I think medical schools are beginning to see that for whatever reason, I can highlight several of them. You probably have several of your own, but for regulatory requirements, from a quality and patient safety standpoint, from a billing perspective and note documentation, increasingly students are being viewed as a liability by resource and time. Not a legal, but resource and time piece in the clinical learning environment. And it's becoming an increasing issue for medical schools to think about capacity and reimbursement and faculty mentorship from student placement in the clinical learning environment. So medical schools are, you'll see the term here at the bottom, value-added medical education, which first appeared in the literature in 2014 by Lin and Schillinger et al., so third citation down, that we expanded in a couple of other papers. And we define it as experiential roles for students in practice environments that have the potential to impact patient and population health outcomes, costs, or other processes within the health system while also enhancing their education, whether it be clinical or health system science, knowledge, and skills. So that's really been a focus. Several medical schools now are beginning to think about creative models where we can integrate students in to the health system, into that clinical community of practice to begin to shift that balance more towards the asset. This comes from a study that I couldn't fit on the citation, but we published this in Academic Medicine just a few months ago. It came from a workshop with several hundred educators, and we were and health system leaders trying to identify how can students increasingly add value. And these were the domains of areas where medical schools have identified and are piloting how students can add value. They can add value increasingly so in direct patient care. Students have time more so than many other providers or members of the care team. They can take a more enriched history, particularly through identifying patient barriers to care. They can provide evidence-based medicine, quote unquote, consultation services to the team, and they can be patient educators and advocates. The idea of care extenders is one that's being piloted in several medical schools, how students can be clinical process extenders, whether it be a transitions program, a patient navigator program, which I'm going to comment on in a second. Safety analysts, to place students to be ethnographers in, for example, as we did here at Penn State, place students in the emergency room for 12 hours, 14, 16 hours, give them prompts, I'll give them the tools by which they can observe, and identify insufficiencies within the healthcare system that are patient safety issues, that are quality gaps. And sure enough, the students come back, and some health systems hire ethnographers to go do this. Our students come back and they're reporting out to our ED and quality teams, and the things that they're identifying are the same issues that are being identified within the literature for ED insufficiency. And QI team extenders, population health managers, the idea that students are linked with physicians and other informatics and quality experts to manage a population of patients, not to observe, but to develop the informatics skills and the quality and value skills and competencies, and then improve health for that panel of patients, i.e., they extend the work of the health system rather than just observing. And also, research and systems projects are taking on a new place. This is our conceptual model for um, this topic area. This we published in Academic Medicine a few months ago. And the current education model typically places students on the left outside of the right, which is the clinical community of practice where patient-centered care is provided. And I have in red boxes here the three clinical experiences for students. Preceptorship certainly is a key piece of all medical schools. Service learning opportunities, which have been around for 40 or 50 years. And 30 to 40% of medical schools have student-run free clinics um, for very short rotational events. But by and large, they follow a physician-centric trajectory and pathway into that clinical community of practice. And there's a large chasm in this model that says you can't really get into the clinical community of practice until you become a physician, until you get your degree, the MD degree or DO degree, and you get there after maybe even into the second or third year of residency, maybe internship year. And then you're able to add value and extend that work. What we're hoping for is that we're trying to develop a different professional role identity for learners. And we believe that we need to get our learners into the clinical community of practice, and it doesn't need to be through the physician trajectory or pathway. They can be integrated into the team to do a number of tasks that are authentic, that are legitimate participatory roles within the team model for patients. And by doing so, it's going to increase their self efficacy, their internal motivation for the healthcare system, for that patient. And in so doing, we hypothesize that they're going to learn more. And this is the conceptual framework for a lot of the value added roles. This is an example of what we do here at Penn State. Again, within that first month, they're enrolled in the course, which is the right-sided component, conceptual component of 100 plus contact hours. We have a whole new bench of educators, which is a fascinating topic in and of itself for me. This my whole job is really reaching out to whatever role you are on the phone, anywhere in the health system, you are likely an educator within our course. And typically, if you were to look for educators within a basic science course in a medical school in biochemistry, you would walk down the basic science hallway, or if it was a gastroenterology course, you'd walk down the gastroenterology suite, and your faculty are in that pod. For the health systems course, our educators are coming from every nook and cranny of the health system. They are the CQOs, the CMOs, the vice chairs for quality, the physicians who take an active role in high value, cost conscious care, and they are teaching in this course. This prepares the students for practice in their patient navigator roles, and this is their experiential value added role. Patient navigation sprang forth in the 80s and 90s from a breast cancer surgeon in Harlem who identified that he had a lot of female patients coming to his office with ulcerating breast cancer lesions, and he could not help them. It was too advanced for surgery. And out of some frustration sprang forth his quest into the neighborhood and into homes to figure out why these patients were coming to his services late. And he identified that patients need more education. They need more facilitation of healthcare resources and access to resources to receive better outcomes. They need psychological and emotional support. This model has expanded to a number of different healthcare areas. We molded this program for students. Our students are embedded as patient navigators across 41 clinical sites. They are mentored, 96% of them, by interprofessional non-physicians, care coordinators, nurse navigators, um, care managers, and 66% are co-mentored by physicians. But we want them to extend the work of the clinic. We want them to do. And in many ways, that's happening. To date, they have navigated somewhere in the ballpark of 1,200 to 1,400 patients in the past 2 or 3 years, and we're looking at some outcomes for that, which is very challenging to do. But these two parts of the course work synergistically. I just wanted to give you a taste test of a value-added role. And this is one clinical vignette. This is an example from an internal medicine clinic. Two first-year students are embedded into a care team with a care manager, social worker, physician mentor. They're linked up, in this case, an 84-year-old female with several comorbidities. They identify the patient through reviewing data logs of the no-show rates within that clinic. Through in-clinic discussions, calls, and home visits, they acquire a really enriched social history and identify her reasons for the no-show rate. They, through the home visits, through these discussions, they identify and help facilitate the access of a motorized wheelchair, an in-home ramp, walk-in shower, dependable source of transportation, things that really matter for this patient's life. They help her apply for public assistance. It doesn't go through. It's a lengthy process, but the students learn in that experience about public assistance. And they also identify the lack of a social network for this patient, and they are able to identify a number of community-based resources to help that patient, which we know that there are direct relationships between the social network and patient's outcome, depression, and other diseases and illnesses. So you can see how they map. I think in former years, one could argue that this is a service learning project, or it's not, it's more service than it is adding to their education. But with the health system science competencies, you can see that they map to a number of these competency areas. So we're down the home stretch. So Angelica, this is question 3.
Thank you, Dr. Gonzalo. So, audience, you see the question in front of you. Who should be teaching health system science? Should it, number one, be physicians, health system leaders as your number two, e.g., the CMOs, CQOs, CNOs? Number three, community-based care managers and nurses. Number four, other interprofessional providers. So, in your opinion, who should it be, audience? Right now, where health system leaders are coming up on top, Dr. Gonzalo, about 70%. There we go. Just give a few more seconds to let the rest of the audience participate. 6% are saying physicians. Let's see. All right. I think we're there. So let me just bring that up. Wow. Okay. It's collecting the responses, Dr. Gonzalo. But right now it's showing that 6% believe it should be the physicians. 72% are saying health system leaders. 11% the community-based care managers and nurses. 11% the other interprofessional providers. So is that what you're typically finding in terms of thought, Dr. Gonzalo?
Yeah, this is a little bit of a trick question. I've never asked this question before, contrary to the second question, the last one we've just asked. And I'm going to comment on it in a few slides, but this is the current status of the evolving landscape of health system science, because the educator cohort, the educator profile, we are in the midst, again, in my opinion, of a transformation about who our educators are, who our faculty members are. The fact that a low percentage are being identified as physicians in that role, I think, I don't want to get into the hearts and minds of our respondents, but I think based upon the answer to question 1, we haven't been educated and trained in a good system of education, and we're lacking the competencies. There's a paucity of those physician mentors and supervisors and preceptors that are able to role model these. So we're shifting a little bit to these other individuals, and I think this is a fascinating concept. I'm going to come back to it in a few slides, and that brings me to my last concept, the one that says integrating health system science into education and care delivery is a challenge. And I've been increasingly using this theme in a number of my talks because I think I anticipated this coming in 2013 to my role, both locally and nationally, that there would be challenges. The challenges in these areas are tremendously high and strong. And I think I've become a student of trying to understand and help navigate why these happen and how we could navigate around these issues. And I don't have the answers to this, but I'm going to highlight some of the challenges we see. So when we would get on our phone calls to the AMA consortium, as I said, many medical schools are working on this. We'd get on the phone and we would find ourselves having war stories, um, discussions about what our challenges were, what we're hearing from the front lines, where the resistance and tension is coming from, because you get tension and resistance from nearly every stakeholder group to some degree. There's a diffusion of innovation model of participants and stakeholders and how engaged they are. There are plenty of people across every stakeholder group that is fully engaged. And there's also those in the middle and also those at the back end of that curve. So we articulated this. This is work that I'm highlighting the citation at the bottom. This came out, I think, just a few weeks ago in Academic Medicine. What do we hear from the front lines about some of the concerns for health system science? And the boxes, there were two main themes. The first one was the importance of learning health system science. And these were some of the complaints or issues that we would hear. If medical education isn't broke, don't fix it. Many individuals say to us, I'm doing just fine. I'm a physician. I love my job. I'm doing pretty darn good. So where's your data that suggests that medical education is broke? You're fixing something that is not nebulous and you're not zeroing it in. And I think as evidenced by the first question on this call, I'm probably talking to the group that would agree with the counterpoint that says, there are issues in healthcare. We're all in a learning organization, a learning system, and we could do better than the current status. Number two is health system science is too complex and best learned in residency or practice. There is some truth to this. I reviewed the clinical learning environment slide with you. This is not an easy linear thinking transfer of memorize these four tenets of value-based care. It's really learn within that context, and it is challenging. The counter to it, at least in my mind or many of the educators' mind, is that we need to develop a different professional role identity. And to do that, we can't tack on an elective the last 2 weeks of medical school. It needs to be part of their living and breathing identity in the healthcare profession that ideally should start well before medical school. Again, that's a hypothesis, that's a view, and we need healthy dialogue around a lot of these issues. The third is that early students don't have the skills to contribute to healthcare and the roles already exist. The value-added roles I described, they're not well published in the literature, and in my view, they do not exist, particularly before a few years ago. And these medical students are smart. I think traditionally we kind of place them in this physician trajectory. But to do these types of value added roles, they do have the skills. They are very bright. If they weren't coming into medical school, they would be highly coveted or highly sought after employees in nearly any field. They're brilliant. We just need to change the structure a bit to challenge them, to place them in a different structure by which they can add value because they can. The last is health system science is not yet a true science. And I think there is some truth to this. We place the science lens on this. Um, some folks argue that a lot of what's in that framework of value, of quality, of teamwork, of informatics, they're not true sciences. And they'll pull up the definition of science, which I've done at least 20 times, and it's conceptually hard to do. I think the counter to that is what's the concepts and the competencies, teamwork science, quality improvement science, population and public health sciences, that this is really built upon foundational sciences. But again, I think it's a healthy dialogue. I think what the framework has done has begun to establish this as a key part of medical education, not a one-off. The second category are practical concerns. One, there is a limited space in an already packed curriculum, and this is absolutely true. Where does this go? How does this fit? Everybody who talks to me about this said, well, how did you fit all these contact hours in? And it takes, there's some challenges with that because you do have to think hard about what quote unquote is removed from the curriculum. And my view is that there is some fat to be trimmed from preclinical coursework and shifting away from knowledge transfer and memorization in a day and age of technology and data towards higher order competencies on how our learners and healthcare professionals in real time assimilate data. We have a lot of data at our fingertips. maybe we should be shifting more to those types of skills rather than the knowledge transfer. But this is a very prominent concern, and there is some legitimacy to it. The second is few faculty have the knowledge and skills to teach HSS. And I think our participants on the phone have highlighted that a little bit through the questions, and this is definitely true. A lot of folks come to me and say, well, we can't do this at our medical school because we just don't have a department of X, Y, or Z, or a division of healthcare delivery science, or we don't have these folks. I would say that they do exist in the health system. Again, they live in every nook and cranny that of the health system that is allowing the health system to stay solvent on an everyday basis. Um, but I do think there is a significant chasm in our current educators to role model these competencies in the clinical learning environment. The third is accreditation agencies and licensing boards do not support medical education transformation. Um, we have not found this to be tremendously true. I think in many ways they are supportive of transformation. We've just piloted a board exam. The National Board of Medical Examiners and the AMA have come together on piloting a set of health system science questions that I know of 11 schools that have used it over the past year. So there is a shift that is moving, and I don't think they're big um, barricades to transformation. And evolving health systems are not ready to partner with schools with HSS curriculum. I think when I went into the job, going to all these different sites to build new navigator roles or develop all the curricula, I thought, oh boy, are people going to be behind this? What I have found is that when I go and sit down with a chief quality officer, the chief medical officer, or the CEO, or the vice chair, or a physician lead, nearly 100% of the time, their response is yes. I see the importance of this. This is so critically important. I am in this with you. What do you need? And the receptivity to this from that tier has been tremendous. Um, the challenges are how to coach them into new educational methods. But I do think evolving health systems, for the most part, are ready to partner, but there's more work to be done. I need to highlight this. I'm citing it at the bottom. This is work that we did prior to launching all of our work. What's the student perspective on this? And we sought to identify the main challenge going into our curriculum. And we did a whole bunch of focus groups with students. And this is essentially what they told us. They said on the left side, this is the current system we're in. That basic and clinical science courses are what matter for our grades and board exams. The board exams, the content maps for those board exams literally are 97% laden with basic and clinical science coursework. There's 3 to 6% that might have quality improvement or patient safety. But the students are saying you're placing us in a system where that is our main focus, and that is our golden ticket to the best residency program. The residencies are looking at those board scores and the examination scores and coursework. We understand the right side. The balance of this is critical. We had a calling to come into medicine, to develop those patient-centered skills to be the best doctor possible. But these two pathways are at odds. They're not blended together too well, and we're often pushed and constantly pushed to the left. And certainly that has turned out to be true. Locally, I mentioned the diffusion of innovation curve. There are many students who live this out, that they are focused on that left side. They may not come to class. They may not fully engage in this. They might have issues with a large degree of health system science learning in the medical school. And you do have a lot of students who blend them together and say, you know what, they do great in their coursework. They focus really hard on their basic and clinical sciences, but they also live and breathe patient navigation, and they're fully early adopters and early engagers in this work. This is a key piece of educational innovation in my book because the structure is currently designed. I think those in education know that that's the way it's designed. But we are living through a lot of major challenges that it's not easy on the ground. This is my last slide. I have it entitled Health System Science as a Call to Action. I think there are many implications for this. I just highlighted two here just to open up the discussion point, which I think we've already discussed a little bit. The first is the expanding educator bench. And I've already alluded to this. This is a phrase that I use very frequently, that the educator bench in a college of medicine with the third pillar that centers around health system science is expanding. We are calling upon and in many ways expecting other individuals within, whether it be in a medical school or a community-based academic hospital, we're calling upon different individuals or individuals to think differently about education. And it might be through new roles, especially interprofessional providers, our care coordinators, our patient navigators, who have never been called upon before to teach. If we were to ask those site mentors in the Navigator program, do you view yourself as a faculty? Overwhelmingly, they would say no. They do not get protected time. They are not paid. They are not reimbursed. They have never taught in a medical school before. The same thing if you go to the CMO, the CQO, they say, yeah, Jed, I will help you with this, but I've never taught before in a medical school. What do they typically learn? What do the sessions look like? So there's new roles that are expanding the profile of educators. And then the evolving roles. I think I mentioned this about the clinical preceptors, whether it be in the operating room, hospital-based ward, or primary care clinic. There's a different blend of the type of mentoring that needs to happen with these individuals. If you're a hospitalist physician and you've been around for 20 years since the hospital's name came forth 20 years ago, what you have typically educated about or mentored or supervised in the clinical learning environment for the past 20 years, much of which was not focused on health system science. Now, as our learners leave the first 2 years and they go to the clinical learning environment, they're they're posing questions about value. Do we really need that CT scan for the ENT consult? Where's the evidence behind that? Is that the most high value, cost conscious decision that we can be making? The faculty members need to be role modeling and responding to those types of comments. And I think it's causing some, particularly physicians, to think differently about their roles, some with positive receptivity and some with the opposite. And my last point is the new culture required in medical education and healthcare. There's a need for better integration of academic health center missions. And I understand some of you may not be in academic health centers proper, but I do believe that health system science is one way that is beginning to bridge the education, research, and clinical missions. A lot of my job is centered in the medical school, but there's a good other leg of my job that is within the health system and thinking about the researchers who do a lot of this work and the clinical operations piece of this that is beginning to merge. Health system science to me is a linchpin that is beginning to integrate together better. So I think it's a call for action for medical schools and health systems to work together to be leading the change rather than susceptible to or receiving mandates from others in the years to come to shift the educational processes. That is an opinion of mine, and I understand there might be differing views, and I respect those as well. So that was my last slide. I'm hoping that I was able to address these four learning objectives, describing health system science, the need for the clinical learning environments and value-added roles, and discuss at least some of the challenges. There's many more to integrating health system science and medical education. So thank you very much.
Well, thank you, Dr. Gonzalo, for leading the session and showing us where healthcare systems are going in this 21st century here. Now, audience, it is time for the question and answer portion. Feel free to type in a question using the questions pod in your console and just hit send, and I will read those off to Dr. Gonzalo. We thank you very much for joining us today. Dr. Gonzalo, we do have a couple of questions that have come in. The first one is, are there strategies we could be using to better prepare faculty or the teachers to work with learners in these health system science areas?
Yeah, absolutely. I alluded to it in the diagram of what we're doing at Penn State.
Hello, Dr. Gonzalo, can you hear me?
Yes, I can.
Okay, I think we just lost you for a second.
So I think, can you hear me, Angelica?
I can.
Okay, so I alluded to it here at Penn State, our faculty development program. I think that is one piece of shifting the dialogue and also the knowledge and skills for faculty educators, particularly in the clinical learning environment. We can't just place new educational curricula and expect these knowledge and skills to spring forth. We need to seek to continue to change the hearts and minds, at least even slowly over time. And that might require faculty development workshops. It might require education for evaluation measures or the development of assessment and evaluation tools. One of the key challenges is that there's not a lot of assessments and evaluations that are valid and reliable in the clinical learning environment in these areas. And that becomes a challenge in and of itself. So there's a ton of more work that this is not on all faculty preceptors. All of us need to work together on moving it forward. But I do think education is a key piece. And in webinars like this, beginning to shift some of the language and dialogue and the participants to go back to their meetings, wherever they may go, and shift the discussion and have an awareness that medical schools are doing this. This is, to me, the bus has left the station on all of these concepts. If a pre-med student came to me and said, tell me what I should be looking for in a medical school, my first thing would be, if your medical school is not preparing you for the system in which you will be providing care or practicing, And at this point, for a student coming in next summer, that's 2022 until they're in residency, plus 2025. Schools need to be working on that now. So I think it just merits further dialogue.
Thank you, Doctor. Our next question is, what can participants on the call be doing that could help accelerate this transformation in their local settings?
That's a great question. I think even I kind of alluded to it here just a moment ago, but shifting some of the dialogue even amongst your internal local group, no matter what your role is. And again, this doesn't have to be physician education. If you look at nursing schools, it's shifting there. There's nurses on the phone to be thinking about your curricular map. If you're in the Department of Quality and you're a process improvement lead or whatever your role is, to be having those discussions with your CQO, with your health system lead, to sit down with the vice dean for education or the education lead, and to begin to think strategically about where the medical school is going, I think is one critical step to have those conversations. And maybe I'm not sure what stage we're at. Maybe in the local setting, you don't know that we're at that stage to actually have those discussions. Medical schools can never do this alone. I hope that theme has come across pretty clear from my words today, that it really requires everybody in the health system working together to carry forth this mission, because this educational mission is really the health system mission.
Wonderful. Dr. Gonzalo, I think that is the end of our questions that have come in. So thank you so much for your time today and for providing an amazing program. We very much appreciate you taking your time out of your very busy schedule.
Thank you so much. I appreciate the opportunity.
Thank you. And thank you, audience, for joining. Actually, you know what? There is a question that just came in if you still have the time.
Yes.
It asked, our participant asked, do you believe, despite the discipline, that HSS content should be leveled across the curriculum?
I'm trying to interpret the meaning of that question, leveled across the continuum. If I interpret that to mean that it should be balanced across each level of learner, I might be misinterpreting that question, but I would say absolutely yes. Um, again, later in the curriculum is not a conducive strategy to use, particularly when we are focused on developing the hearts and minds of a different cohort of physician or provider that may not currently exist in many niches. To do that, you have to do it very early on. I alluded to the pre-medical school continuum, which I think is definitely true here. Despite the challenges, despite the rainstorms in the first and second year to do this and into the third year, I think we need to weather those storms, because the benefits really are long term, and it's developing a different type of mindset. It's going to take a number of years. I hope I answered the question appropriately.
Dr. Gonzalo, our participant, clarified it's not courses in isolation. So does that affect the answer?
So if I could rephrase, then maybe the question might be, should it be done in courses in isolation or integrated with the other coursework, Angelica? Does that sound like that's the question?
Um, yes, I hope so.
Yeah, I hope so too.
Okay.
Sorry if it's not. This is an active area of scholarship for us actually, because the genesis of comprehensive curricula such as this have occurred over the past 3 or 4 years, and we don't have an evidence-based foundation about what is best. And my mind goes both ways. At Penn State, you can see it's pretty clear. We are integrating into other courses, but primarily they are standalone courses that run a continuous thread. And there's reasons for that. One of the primary reasons is the receptivity by those course directors in other areas to integrate it in. A lot of folks, they stake claim to their content area. They want to cover maple syrup urine disease, and they want the 8 or 10 hours on the Krebs cycle. And that integration, there is a chasm there. So we have a reason why we have a standalone course. The ideal, though, I think, is to be determined. And clearly, it needs to be that tripartite 3 pillars integrated. And I think it needs to be lived out and breathed out as it is in the clinical setting, of all of it tied together, working synergistically. And I think we're several years off of that. It's a culture shift. It's going to take a while.
Hmm. Well, thank you. I think that is our final question. So thank you, Jed Gonzalo, and thank you, audience, for being with us for Health System Science Education, preparing the 21st century healthcare system. So please stay tuned for more messages from us within the next couple weeks. We're finalizing our January webinar, which should be a great one. I want to bring your attention to a couple of other things happening with the college, including our next annual meeting, Medical Quality 2018. We have an amazing lineup of speakers, including keynotes by the U.S. Department of Veteran Affairs Intern Undersecretary for Health, Dr. Carolyn Clancy, our 2018 Founders Award winner and a legend in the field, Benjamin Chu, as well as a very interesting story of Marcus Friedrich, who is a former banker and now the Chief Medical Officer of Quality and Patient Safety for the New York State Department of Health. It is also our time, just to remind the members in the audience, to remember to take care of your 2018 dues. Benefits to the college provide you access to various outreaches, including preferred pricing on our annual meeting. So you're very important to us. It's particularly this particular virtual speaker session is through the efforts of our dedicated volunteers. They're your peers, doctors, nurse practitioners, etc., who are on our education committee. So thank you very much, audience. You will be receiving a recording of this program as well as a survey evaluation. So I ask you to please fill that out because your opinion is important to us. Thank you so much. You may now disconnect.